So T-cell acute lymphoblastic leukemia is a really underserved population at relapse, because we know that at relapse the prognosis is really dismal. So CAR T-cell for TLL pose a very difficult problem. Why? Because CAR T-cell are T-cells. So if you manufacture and you do not have a leukemia-specific target, the CAR will kill themselves. So it's called fratricide, or by the Americans, friendly fire. This is the first problem. The second problem, in BLL, when you destroy normal B cell, you can live without B cells if you substitute with immunoglobulins, which is the case of the first famous Emily Whitehead patient. She still received immunoglobulin 12 years after. But you cannot live without T cells. So T-cell aplasia is to be prevented or treated. And the third problem is because T-cell blasts are looking like T-cells, contamination during the manufacturing process is very difficult to prevent, because if not, you will put CAR in a blast, which is not what you would like to do, obviously. So these are the main problems. And also, if you talk about allogeneic CAR, then the problem is you risk to induce so-called graft versus host disease with a T-cell bearing the CARs that you infuse, which are not the same HLA type than the recipient if you do allogeneic CAR T-cell. So at the moment, all these problems have been tackled, and very elegantly. The first one, which is, I would say, the predominating model, is to say, let's abolish the target inside the CAR T cell, and I will look for this target on the leukemia. So the antigen, which is the most fashionable at the moment, is called CD7. So there is a very elegant way, either by knockout or by retaining the information, retaining the protein inside the cell, not at the surface, so that the CAR T cells do not express any more CD7, so there is no fratricide. So this problem has been overcome. The elegant way also to say, I would like to give allogeneic T cell, CAR T cell, is to say, I will destroy the TCR, the T cell receptor. So this has been done by many methods, including CRISPR, and more elegantly with base editing. So there is a beautiful English publication in the New England Journal of Medicine with 3 patients being edited and received allogeneic CAR T, autologous CAR T, allogeneic CAR T, and then brought to transplant successfully, at least in 2 of the 3 cases. So these are, let's say, embryonic results. And there is also a nice company-driven, biotech-driven results with 25 patients with a very promising overall response rate at the recommended phase 2 dose, which is pretty high, 900 million cells, flat dose, which is 6 times what we infuse generally. But with this dose and with the adapted conditioning regimen, it was presented at ASH 23, the overall response rate is 100%. Obviously, these are allogeneic CAR, they do not persist, you will need probably a transplant for most of the patients, but let's say that compared to a few years ago, the field of CAR T cell for T cell ALL is advancing a lot.